Great. Can everybody see my screen? Okay.
Yep, in your full screen.
Okay, great. All right. Hi, everybody. My name is Shivani Sundaram. I'm a third-year med student at the Keck School of Medicine in the University of Southern California.
And my name is Kung Liu. I'm a third-year medical student at the University of Wisconsin, School of Medicine and Public Health.
And we're going to be presenting a paper entitled Post-Surgical Electrical Stimulation Enhances Recovery Following Surgery for Severe Cubital Tunnel Syndrome, a double-blind randomized controlled trial, written by Power et al. In 2020. Okay, so quick introduction to cubital tunnel syndrome. It is a compression neuropathy of the ulnar nerve as it passes through the elbow. There are different common etiologies for the compression. One example is when the ulnar nerve passes between the medial epicondyle and the olecranon process. Another common cause of compression could be when the ulnar nerve passes behind Osborne's ligament. And essentially what happens is with compression of the ulnar nerve comes intrinsic muscle weaknesses, pain, and paresthesias of the regions that the ulnar nerve innervates. So in a spectrum of severity, those who have less severe CUTS just report sensory changes, specifically in the fourth and the fifth digits of the hand, which is what the ulnar nerve innervates. However, those who exhibit more severe manifestations of the disease will also report motor weakness, specifically involving flexion of the hand, grip strength, and lifting heavy objects, as the ulnar nerve also innervates the lumbricals and the interosseous muscles of the hands. So initial treatment of CUTS is conservative. This involves behavior modifications such as limiting repeated flexion of the elbow and also avoiding resting the elbow on stable, sturdy objects for long periods of times to alleviate the inflammation. In addition, other conservative treatment modalities for ulnar nerve compression include bracing of the elbow in the nighttime and also controlling pain with analgesics such as NSAIDs. However, those who are refractory to conservative treatment, patients who exhibit an increased severity of symptoms, specifically without resolution in about 6 to 12 weeks, or those who exhibit severe axonal loss as a result of this pathology are candidates for surgery. Despite the fact that the surgery has been around for a while, a lot of patients actually have less clinically significant recovery. And this is thought to be because peripheral nerves lose their capacity to regenerate the further along you get following a neuropathy. So because of this, a new novel treatment for CUTS has been developed called post-surgical electrical stimulation, which we'll talk about in the next slide in a little bit more detail. But it's thought to increase the regeneration-associated gene expression in peripheral nerves and thus accelerate motor and sensory axonal outgrowth. Therefore, for this reason, the hypothesis that this paper presented was that performing PES post-cubital tunnel surgery in patients with ulnar neuropathy will improve muscle reinnervation and improve functional recovery.
And so briefly, we want to kind of explain what post-surgical electrical stimulation is and how it may work. And that we found that in human model and other kind of animals model, we can kind of isolate the target nerve, in our case, it would be the ulnar nerve, and then identify the point of compression or cut and provide kind of 1 hour, 20 hertz stimulation proximal to the pathological point. And this helps the nerve kind of reinnervate the specific muscle. And it's kind of been established in literature for rat, mice, and in other human conditions like carpal tunnel syndrome and finger nerve laxation. The reason we mentioned 1 hour is that more than that seems to make no difference for motor nerve in terms of regrowth, but more than that for sensory nerves seem to hinder their regrowth. And the significance of the electrical signal is that it's likely help stimulate some sort of protein signaling cascade that help with structural regrowth in the neurons and the supporting cells around that neurons. And so in looking at the study, we frame it in a PICO model of asking, in patients with severe cubital tunnel syndrome, does the addition of PES in addition to surgery for the ulnar nerve help improve outcome? And severe cubital tunnel syndrome here include hand weakness, which is further quantified using EMG of the hand muscle and exacerbation of motor unit in those muscle innervated by the ulnar nerve. And the study design that is randomized patient into control and PES stimulation group in a 1:2 ratio. It's double-blinded and it's analyzed with the intention to treat. The outcome is tracked during a 3 years follow-up period using both electrophysical measures like Moon and also functional measures like grip and pin strength, mainly because these strengths are handled by muscle specifically innervated by the ulnar nerve. Quickly glancing at the table provided here, we see that the distribution of subjects, and we see that there's no significant difference in the demographic, the character of the symptoms, or the pre-op electrophysiology measure or functional measure.
Okay. So I'm going to quickly just talk about some of the values that Kwong mentioned in the previous slide. So one of the measurements that the researchers used was the compound muscle action potential, also called CMAP, which is defined as the maximum action potential generated specifically in the hypothenar muscles as quantified by using surface electrodes. And these electrodes were specifically placed over the hypothenar muscles to avoid signal contamination from the median nerve, which crosses the other side of the hand. Another value that they used to quantify the electrophysiologic signals was the motor unit number estimation, which is essentially a raw number of actual hypothenar motor units that are recruited during a muscle action. And the researcher talked about how MUN was technically a more accurate measure of nervous system regeneration, because a motor unit, loosely defined, is just a motor neuron plus all the neuromuscular junctions that is involved and that it innervates. And for that reason, an increased MUN actually points to more regeneration capability being possible. So an instance where the CMAP would increase while the MUN would remain the same is if the remaining axons present in a muscle group would actually grow, or the remaining neuron would grow neuroaxons and new terminals in order to compensate for muscle loss. So it's a less sensitive measure for regeneration as well. But also just going through the protocol, so people who met the criteria for the study and had severe CUTS underwent surgery. There were two different kinds of surgeries that were used, however. The majority of them underwent in situ decompression, which is where the ulnar nerve was kind of detached from the point of compression. Some individuals had to undergo submuscular transposition, which is when the myofascial flap was actually lifted above like the flexor pronator muscle group in the elbow as well. So it was a slightly different surgery that was used in order to optimize patient outcomes. Before the incisional closure, 2 electrodes were planted along the ulnar nerve. The incision was closed, and in the post-anesthesia suite, individuals underwent PES. The control group underwent 5 seconds of PES, and the study group underwent 1 hour of PES. And those were the 2 different treatment modalities that were used for these patients. And finally, they were post-operatively followed annually for 3 years. And at each visit, researchers quantify the CMAP, the MUN, the grip strength, and the key pinch strength, and use that to go analyze their data, which we'll talk about now.
All right, so let's look at the result. And the first one we're going to look at is the electrophysiology measure. These tables kind of compare how these patients in the control and the stimulation group progresses yearly 1, 2, and 3 post the operation. And looking at MUN, which is the estimation of motor units here, we see that the control group did not make any significant change from this baseline measure pre-op, even 3 years after the operation, while the PAS grew almost 6 times the number of motor units at year 3, and we actually see a significant change starting at year 1. Similarly, for the motor nerve conduction study, the control group did not make any significant change, and the stimulation group see meaningful result at 2 years and then 3 years.
Okay, so now just to quantify functional strength. So it's worth mentioning that preoperatively, there was no significant difference in grip strength or key pitch strength between the control group and the PES group. However, for both grip and key pinch, there was a significant improvement in strength across the board for following all 3 years for the PES group. In addition, the researchers quantified a value called the MCID, or the minimally clinically important difference, which is essentially the change in strength that is necessary to be quantified as a significant increase in strength. So this was calculated by using 50% of the standard deviation of the mean preoperative grip strength or the key pinch strength. In other words, if the MCID for grip strength was 5.9 kilograms, an individual would have to see an improvement in grip strength of 5.9 kilograms in order for it to be considered significant. So for this reason, the control MCID for grip strength was only 4.2 kilograms. So it's therefore an insignificant improvement with a p-value of 0.08. However, the PES group grip strength MCID was 8.1 kilograms, which is a significant p-value, which is why they had a significant improvement in grip strength. A very similar trend is seen for key pinch as well. The MCID was 1.1 kilograms as calculated, and only the PES group actually saw an improvement of this much or more at 1.9 kilograms, which is a p-value less than 0.001.
So I want to take a pause and just summarize the takeaway that we interpreted from this article. And the main point that we saw was that in patients with severe cubital tunnel syndrome, surgery, in addition to PES, afterwards showed significant changes in both the reinnervation and the physiological measure from that, but also the functional performance at 1 year and 3 years post-op relative to the control. We also want to compare the result here with the background and previous studies done in this field, and that the control and the lack of improvement is comparable to those in kind of the established literature by Zimmerman in 2013. This is important just to say that the study group that we have here is someone, or the people who are comparable to other people, around the globe or in a different country, and that the improvement we saw in the simulation group is just not some sort of anomaly. And similarly, or a different comparison is that this study found that people with chronic cubital tunnel syndrome and the chronicity of the symptoms did not impact the outcome and recovery, as opposed to Bruder in 2017, which found that chronicity did impact the outcome. The author explained that in the earlier study, follow-up was only done in 6 months, and that was not enough to see meaningful results.
The authors also concluded with the discussion of the limitations of this study. So for one, there was a lack of objective assessment of pain and sensation that the patients had. And so the most significant side of or symptom of CUTS is muscle atrophy. And in previous papers, the authors showed that there was like increased regeneration of sensory nerves because of PES. So because of that, they assumed that this would lead to an improvement in pain and sensation, and then chose not to quantify those variables. In addition, there was a relatively small sample size for this paper, which is why they chose to do a 2-to-1 treatment allocation. So double the amount of subjects in the PES group as compared to the control group. And they did this in an effort to increase the significance of their results. And finally, a possible confounding variable for this is the fact that there were 2 different surgical techniques utilized depending on the needs of the patient at that time. However, past literature has showed that there is not a significant difference in outcome, or in patient outcome and strength, depending on what surgery a person underwent. So this is possibly less of a consideration, or at least the authors said so. In addition, they also talked about how feasible PES actually is. It's a relatively inexpensive treatment modality and requires minimal training and does not add much operative time to a decompression surgery. The one concern that they did bring up is that in its current form, PES does require a patient to be under general anesthesia, and there's now more of a push towards using local anesthesia when doing the decompression surgery. However, this could possibly be modified by just stimulating the nerve well with PES proximal to the site of local anesthesia. This would have to be something tested and trialed up, but there's a great future for PES and cubital tunnel surgery.
And we included the slides, Randy and I, just to make sure that what we've said in the last 10 minutes makes sense to the audience. So we kind of have these 2 vignettes that I want to present to the audience to see if to tell me if what potentially the diagnosis of these patients are, and if the treatment plan or the treatment proposed in this study would help each of them. So the first patient we have is kind of like John, who's a 50-year-old man who has a history of carpal tunnel syndrome, status post tunnel release. He presents today with worsening right hand weakness. He also has a 3 years history where he had trouble tying his shoes and carrying boxes. Looking at his hand, there's hyperextension of the MCP joints of the pinky and the ring finger. And as opposed to Tracy here, who's a 33-year-old woman, she has recurrent houselessness presenting with right hand numbness. And she said it's especially worse after this kind of jazz hand street performance, repetitive hand movement. So could someone in the audience kind of tell us what each of the patients might have, and if PES stimulation and cubital tunnel release surgery would be helpful to each of them?
If you guys don't have access to the chat function, you can use the Q&A as well to throw in answers, and I'll be able to see them. You can also raise your hand and I can unmute you. Okay, well, if no one's feeling participatory, that's completely fine. But yeah, I would love for you guys to, tell us more about these patients.
Yeah, so the patient on the left versus the right. I'll go on the patient on the right first. So patient on the right, recurrent homelessness, just is implicitly imply that she sleep a lot on her elbow, and this can lead to cubital tunnel syndrome, and she get numbness, paresthesia when she does this hand movement, which then stresses the elbow and with repetitive hand motion. But she has mild, I would say, assuming that she has cubital tunnel syndrome after the workup, her symptoms are very mild. And so this study looked at more severe symptoms and severe presentation, like John, who have weakness, which is this after numbness, the muscle then also become weak, and there's hypertrophy of the muscle. And so then this leads to dexterity problem with carrying, tying shoes, and then strength problem with carrying boxes. So for someone like him, he's very much similar to our study population. And so the PS stimulation might be helpful for him. But for Tracy, the study, I think, did not necessarily look at her population, and application can varies in how outcomes is.
That's all we have. Thank you so much for your time, and we're now open up for any questions.
Thank you guys so much. And Dr. Wilson, if you would like to share any of your thoughts on this paper, your clinical experiences, we would love to hear that. And if anyone has any questions for Dr. Wilson as well, feel free to throw them in the Q&A.
Can I maybe just pose some questions to people, and maybe we'll see if we can get some participation? So this study was pretty recent, published just a couple of years ago. I guess, what are people's thoughts on the trial design? Do you feel like this is strong evidence that we should be doing this in everybody? Or do you feel like there are things that are missing that might say, I don't know if I trust this data?
With the way you said it, I'm just going to go with maybe we need more evidence.
Why do you think, though? I guess if, based on the way that this trial is set up, or at least the way that it's reported, do you see anything that's missing that that might just make you give a little pause to the interpretation? It's published in a reasonable journal. Neurosurgery is the sort of flagship journal for neurosurgery. I mean, there are higher impact journals that neurosurgeons will publish in, but as far as the subspecialty of neurosurgery, it's our highest impact journal. So it's published in a reasonable journal. So it made it through the gauntlet of the reviewers, but there are a few things that that give me a little bit of pause looking at it. I'm curious if anybody else has any sort of things that they picked up. If not, I'll at least throw my 2 cents in.
Yeah, I think like that was the question I had, and that's the reason I had in the last slide too, just reading through the paper. It seems like the study population was relatively small, but at least in the distribution of patients, it seemed to be balanced, and there was no significant difference in demographics or the pre-op symptoms.
So let me stop you there.
Yeah.
So I agree with you. It's a randomized trial, and the demographics seem relatively balanced. What do you think about the demographics that they reported?
So it's 75% male and all older male. So I think there's a slight bias, I guess, to one gender.
I would just say I think that they gave very few demographics. It's actually one of the things that's really missing. There are a lot of things that do impact outcomes after any kind of peripheral nerve surgery. So we know that there are some risk factors for poorer outcomes: people that have diabetes, people that smoke, people that are obese, older individuals. All of those things impact outcomes, and they didn't really give us much of a demographic picture or a sort of risk factor picture at baseline. Now, again, it's randomized, so you assume that sort of comes out in the wash, but what if it didn't? What if these groups are really imbalanced in one way or another that really impacts the outcomes? It would have been good to know that, I think, so my personal opinion is that that would have been a much stronger paper had they given us a little bit more of the kind of baseline data. They chose pretty objective measures, I think, probably intentionally. You know, they use these electrophysiological outcomes and quantified grip and pinch strength. You know, they're very objective measures, but they're not the traditional way that clinicians think about assessing patients with ulnar neuropathy. You know, we usually grade people's motor strength for most people on the Medical Research Council MRC grading scale, you know, 0 to 5. Even if they didn't want to use that as their primary outcome, it would have been nice actually to have that, because I think it gives a clearer picture really about what the severity of these patients look like. Like, are these patients that have no hand function, no intrinsic function? Or are they kind of pretty good where they're in the kind of grade 3 range, but still may fall into the severe category on the McGowan scale? You know, that there are a lot of different ways of classifying severities of ulnar neuropathy. If you've ever looked into the literature, there's 5 or 6 that are probably the most common. They picked one, and that's not everybody's choice, you know? So to have just something else that kind of gives you a little bit of a sense of really how severe somebody's ulnar neuropathy is, to make sure that these patients are really comparable, I think would have been good. I think you pointed out too, another one of the, I think, drawbacks. It's, you know, what they did is reasonably done, but they're missing some things that would have made this much stronger had they had a pain outcome, had they had a sensation outcome, and had they had any kind of functional patient reported outcome. You know, to say, did this surgery really make a difference to you? Did this, you know, did the recovery that they saw electrophysiologically really translate into something that was meaningful for people? I think would have been useful, would have really strengthened their statement. I guess those are kind of my thoughts on the trial design. Anybody else have any kind of thoughts on that? Otherwise, I'll give a few maybe kind of clinical thoughts quick, and then maybe we can go on to the next article.
We do have a couple of questions.
Oh, yeah.
Did the authors explain why the control group received 5 seconds of stimulation instead of no stimulation?
Yeah.
I can.
You go ahead, Shivani.
Sorry. I was gonna say, so the authors didn't actually provide a direct explanation of why they chose that. The 2 things that they did mention, however, is that in the past, PES had been employed for like at least an hour in order to see any kind of functional improvement. So the 5 seconds of stimulation was not thought to really count as a treatment modality. In addition, there are, again, possible confounding factors of like the placement of the electrodes, like recovery and the anesthesia, all of which have to be controlled for. So the very fact of like placing the electrodes and actually performing the actual protocol is their way of, I would guess, their way of trying to dismiss those variables from having any impact on the results themselves. Although, Kwang, if you have any other thoughts, please.
Yeah, I think one thing I would add is that, so I also do some peripheral nerve electrical stimulation research, and the patient can feel the shock when you stimulate them. So by having the 5-second initial shock, it helps, you know, the control group to feel that, oh, I might be getting, you know, the treatment, rather than just sitting there for an hour and not getting anything, and then eventually realizing that they're, you know, in the placebo group too.
Okay. And then one of our other questions was regarding the follow-up over 3 years. Did the authors mention how they ensured that the control and experimental groups had similar strength training, i.e. were the experimental group in physical therapy or any fitness program relative to the control group?
That is a good question. It is not something the authors mentioned in the paper. They didn't talk about other, like post-surgery, any kind of intervention or any kind of strength training, physical therapy that they got. But that's, again, another really good point.
Yeah, for patients that have severe ulnar neuropathy, it would be, you know, generally speaking, a pretty standard part of the postoperative care to have patients in occupational physical therapy. But again, it's another one of those things that they didn't report on, they didn't track. And could there have been an imbalance in the 2 groups that made an impact on the recovery? Yeah, there certainly could be, you know, because they didn't intentionally, you know, I guess, assign any kind of recovery protocol. Again, you're hoping that through the randomization process that all kind of comes out in the wash, but you don't know that because they didn't say that. It's not something that they tracked. So certainly in the studies that I'm involved in, that's one of the things that we track really closely, because you want to make sure that that's not something that's accounting for differences in the outcomes that you see. Very good question. Very astute observation. Well, was that the last question?
Yep. Yeah.
A few maybe kind of clinical comments. So this is the newest thing kind of in the arsenal, this idea of nerve stimulation to promote nerve recovery. And so it's starting to be used in a variety of different scenarios, nerve repairs, entrapment neuropathies like cubital tunnel we saw here. There's some studies on carpal tunnel. There's a variety of places where this is starting to be used, and we're still in the process of really trying to figure out what the optimal stimulation paradigm is, including how intense the stimulation is, but also the duration. What people seem to be finding is that shorter durations actually seem to work equally as well. So the newest data that I just heard presented at the most recent meeting has it all the way down to 10 minutes of stimulation. So the biggest thing for thinking about doing this intraoperatively, which is the way that most people do this, as opposed to in the recovery area, is how long is this going to add to my surgery, right? If I've got to sit there for an hour with a stimulator while the patient is under anesthesia, it really adds cost, it really adds time, it just adds a whole variety of sort of complicating factors. 10 minutes, though, very reasonable. That could be done during any surgery. And so as we find that this is getting shorter and shorter, I think you might see that one of the barriers to adopting this technique goes away. I think one of the things that has kept people from widely adopting this is just that it initially started as an hour and people were like, I'm not going to do that. And as it gets shorter, people are more likely to do it, I think. Plus, we just need better and more studies that really convince people that this is helpful. I think the way that I think about it is that it's pretty unlikely to be harmful. I think we have enough studies now that show that it's almost certainly not harmful. Even if we say it might be helpful, it's one of the very few things that we have that might promote nerve recovery. So to me, it's low-hanging fruit to try. It's very easy. I've started to adopt it in my practice for a variety of conditions. And I think you will start to see more widespread adoption of this as time goes on. The point that you made about this being for really severe cases is true. This has to be for patients that have lost axons, that the injury is bad enough that the axons have been lost. This is thought to promote axonal regeneration. So in mild nerve injuries, it's a demyelinating injury where the axons are intact, but the myelin has been lost. This, as far as we know, doesn't seem to help with that. So for the milder versions of this, probably not the appropriate population. The most dramatic thing in this case is that cubital tunnel syndrome, when it is severe, is really hard to treat. What we tell most people when they have really severe cubital tunnel syndrome is that we're operating to try to halt the progression. We would consider it a successful operation if you just don't get any worse, not necessarily that you even get better. And so the fact that they demonstrated that people improved with stimulation is actually a monumental finding. It is really hard to treat these patients. And to give them any hope that they're going to try to get some function back after an operation like this with a very simple intervention, I think represents a really exciting finding. We need more data, but it's a really easy thing to do. So I'm excited to see where this goes. And I think you're going to see a lot of electrical stimulation and in a lot of different peripheral nerve pathologies. That's the exciting part of this, I think.
I have a quick question about,
yeah, please.
Like future steps for something like this. If we want to get more data, do you just suggest getting another randomized control trial covering some of the weak points that we mentioned and just more patients?
Yeah, I think that's probably right. More patients, so if you wanted to tackle it in the same pathology, I think there are a few design flaws that could be addressed in a little bit better designed trial. Again, to include a few of the things that we talked about, including different outcomes. So a standardized set of outcomes that would be used in most studies would include a sensation, a pain, and a patient-reported outcome metric. Just including those would go a long ways. But I think you could address it by just having more patients. The other thing that almost certainly will happen is that you will also see it just be applied in other pathologies, right? So it doesn't have to be cubital tunnel syndrome. There's a study on carpal tunnel. We're going to talk about peroneal neuropathy with one of the other articles. There's no articles yet for peroneal. It's just waiting for somebody to try to do the study to show that this really seems to apply across the board for entrapment neuropathies. And again, if you were going to design a peroneal study, I would suggest these to address the flaws that we saw in this study so that we sort of iteratively improve on the way that we're doing this. But I think the more studies that you have across pathologies will just convince people that in severe nerve injuries, whatever the cause, whether it's a traumatic injury, whether it's a compressive injury, whether it's an iatrogenic injury, that stimulation has the potential to improve things, and just getting more data across the board will be helpful.
Thank you.
And I think additionally, this idea that you can do it for less time will be an important element to the future design of trials too. You know, you might actually have two different treatment arms, potentially, say a 10-minute treatment arm and a 30-minute treatment arm, to really show that you can go shorter and still get the same outcomes. I think there's more and more data that is true, but you will win a lot of surgeons over if you can make this into a 10-minute stimulation paradigm as opposed to an hour.
It's good insights. Thank you.
Okay, let's go ahead and move on to the next presentation. Just want to be respectful of Dr. Wilson's time. So I think that's Ashley and Marina, if one of you wants to share your screen.
Sorry, I'm just having a little bit of issue sharing my screen.
Okay, no worries. Let me know if you need any help.
I also don't have even a share screen option.
Weird. Okay. I can also, I have your slides here, so I can also share them. All right, can everybody see that?
Yes.
Okay, just let me know when you need to change slides and I'll forward it for you.
Hi, my name's Narina. My partner was Ashley, and we looked at this paper titled Treatment for Ulnar Neuropathy at the Elbow. So ulnar nerve compression at the elbow, which is also known as cubital tunnel syndrome, is the second most common entrapment syndrome of the upper extremity after carpal tunnel syndrome. The most common site of entrapment is actually the cubital tunnel itself, which has boundaries including Osborne's ligament, which is also known as cubitum retinaculum, the medial collateral ligament of the elbow, which is deeper to the structures presented in this figure, the elbow joint capsule, and the olecranon.
The clinical, next slide. The clinical presentation for ulnar neuropathy at the elbow involves medial elbow pain. The early phase is numbness, tingling, and paresthesias that involve the lateral fourth and fifth digits. As you can see from the image showing part of the dorsal part of the hand and palmar side of the hand where the ulnar nerve innervates. And in severe cases, there's a motor deficit, difficulty with fine motor tasks such as clipping fingernails, opening jars, or writing. Patients often do not recognize the initial symptoms and present with sensory and motor deficits. And late presentation decreases the likelihood of a full recovery. And the symptoms are usually worse at night with elbow flexion or for extended periods of time, especially if they sleep with their arms in a flexed position. Some of the intrinsic sources of nerve compression include anatomic structures, pathologic lesions, and congenital anomalies. And the extrinsic factors can include, but not limited to, fibrous tendon or muscle bands, hypertrophied muscles, and vascular lesions, any of which may directly compress the ulnar nerve at the elbow or wrist.
So the diagnosis is typically done with some form of electrodiagnostic test. This is confirmatory and identifies the specific site and the severity. You can also use ultrasound and MRI. There's also provocative tests, including Tinel's and the elbow flexion test. However, those are not necessarily confirmatory. The treatment options are typically either conservative or surgical. The non-operative treatment is obviously the first treatment of choice, and management is effective typically in about half of the cases. This consists of a splint device, some kind of physical therapy, or rehab. In terms of the surgical options, there's simple decompression, and then you can also have some form of transposition with the decompressions. That could be intramuscular, subcutaneous, submuscular, And in some cases, especially in thin patients where there's not a lot of room left to do the transposition, you can do a medial epicondylectomy. So our study was a systematic review that looked at if the surgical treatment or the conservative treatment was effective at reducing symptoms and increasing nerve function, and if the best treatment could be determined using clinical and neurophysiological or nerve imaging assessments.
This picture is showing a simple ulnar nerve decompression. The incision is usually 4 to 5 inches long, centered at the elbow, and the incision may be in the back of the elbow over the course of the ulnar nerve, or the incision may be curvilinear, starting over the intermuscular above the elbow, passing anterior to the elbow, and finishing over the flexor carpi ulnaris muscle. The ulnar nerve is then released by cutting the arcuate ligament, and the nerve is followed upward and released at the intramuscular septum. The nerve is followed below the elbow into the flexor carpi ulnaris and released from any constricting bands. And this is just one approach. I'm sure there's surgical variation.
So with the transposition, you first do the decompression and you circumferentially dissect around the nerve to allow for it to be able to be moved. You'd excise the medial intramuscular septum anteriorly, transpose the nerve, and then secure it with the subcutaneous tissue, in which case you'll place it anterior to a fascial sling, or you can place it within or beneath the flexor pronator mass.
And for the methods for this paper, they searched a variety of databases as listed here and paper cited in relevant reviews. The inclusion criteria included randomized controlled trials evaluating surgical or conservative treatment of UNE, and they excluded case reports. Primary outcome was whether there was clinically relevant improvement in function compared to baseline. They also evaluated primary and secondary outcomes at a short-term follow-up as well as a long-term follow-up. The short-term follow-up was 1 to 6 months, and the long-term follow-up was between 6 months and 2 years.
So they identified 9 studies with a total of 587 participants. 4 of these studies, including 327 patients, looked at the simple decompression versus the transposition of the ulnar nerve. They ended up doing a subgroup analysis of two different kinds of transposition surgery, so the submuscular and the subcutaneous. What they found was that there was no significant difference in clinical improvement between the simple decompression and transposition of the ulnar nerve groups. This was using 3 studies, and about 70% of the participants showed clinical improvement in the simple decompression group, and about 75% of the participants showed clinical improvement in the transposition group. With the subgroup analysis, there was no significant difference either between the submuscular and the subcutaneous transpositions. There was also no significant difference in the neurophysiological improvement, which was using 2 studies to do the meta-analysis. However, they did note that the transposition group overall, including both the submuscular and subcutaneous transpositions, had a higher number of deep and superficial wound infections.
They also found that there was no difference in clinical and neurophysiological outcomes comparing. I'm sorry if you hear that noise, that's a Air Force plane, so if you can't hear me, sorry. I can't hear myself. Okay. Okay. They also found that there was no difference in clinical and neurophysiological outcomes compared the medial epicondylectomy with anterior transposition. And that was one trial that had 47 participants, as well as no difference comparing subcutaneous transposition with submuscular transposition. And that was one trial with 48 participants. There was also no difference in the clinical outcomes comparing endoscopic and open decompression. That was one trial that had 54 participants, for which 56 nerves were treated. They also found that there was no difference in improving symptoms at 3 months follow-up, assessing the effectiveness of corticosteroid injection versus placebo. And that trial had 55 participants. And there was one trial that assessed conservative treatment in clinically mild to moderate UNE and found that avoiding prolonged movements or position was effective in improving subjective discomfort. But they said this trial had low quality evidence. And the reason why they said it was low quality evidence because they did not provide a conflict of interest statement or who funded the study, and the patients were also not blinded. This trial also found that nerve gliding exercise and night splinting did not result in further improvement in clinical.
So the authors essentially concluded that there is no clear treatment that would be best because there was insufficient evidence. They did note that simple decompression or decompression with any form of transposition are equally effective. However, the transposition is associated with a greater likelihood of deep and superficial wound infections. They were also unable to determine if surgical or conservative treatment for UNE results in improved outcomes, as there were no trials directly comparing those two. However, in another study that they mentioned in the discussion, Song et al. In 2012 noted that simple decompression was found to be more cost-effective than any of the transposition surgeries or medial epicondylectomy. So that likely points to simple decompression as the most effective overall.
And the strengths in this study included that they searched different databases without language limitations. All analysis included all participants in the treatment groups to which they were assigned. There was a risk of bias assessment of the included studies, either set to high, low, or unclear. High quality meant that further research is very unlikely to change the confidence and estimate of effect, and low quality was that further research was very likely to have an important impact on their confidence in the estimate of effect, or is likely to change the estimate. All the trials were randomized controlled trials. It included both short and long-term follow-up for outcomes. Subgroup analysis of subcutaneous transposition and submuscular transposition was also done, and there was found to be no significant heterogeneity in meta-analysis with an I-squared of 0%.
In terms of the weaknesses of this paper, first was that they didn't have any studies comparing the surgical to conservative treatment directly, which might have been important for patients who have the mild form of UNE. Furthermore, there was no discussion of if patients received a conservative treatment prior to the surgical intervention. This was data that they mentioned they had pulled from each individual study. However, they didn't discuss what that length was or how that might have impacted their outcomes. Lastly, and I think the most important thing, is the diversity of clinical outcomes that were used by the individual studies. So the authors of this review used a dichotomous clinical improvement outcome, which they essentially said, yes, this patient saw clinical improvement, or no for their meta-analysis. They didn't really discuss the MCID for those scales mentioned by each study. So although there may have been a statistically significant improvement, we're not sure whether or not that made a significance in that patient's life and their clinical symptoms. Furthermore, this paper was published in 2016, so we're not quite sure if there have been new improvements since. Like they mentioned, Shivani and Kwong mentioned earlier, they didn't even look at the PES because that wasn't a significant thing that would be a new development.
And here are our references, and we are open for questions and a discussion, mainly a discussion.
Thank you for having us.
Thank you.
Okay, thank you so much. If people have questions, throw them in the Q&A, but Dr. Wilson, I will yield the floor to you.
So this is a very important topic, just simply because it is such a common thing that's encountered. You know, carpal tunnel is the most common entrapment neuropathy that we see. But cubital tunnel is second. You know, I evaluate multiple patients a week for cubital tunnel syndrome, and you're faced with this question, how are we going to treat them? And so this becomes, you know, very clinically pertinent to try to have some data to try to guide you into how you're going to treat these patients. The interesting thing that none of you will be privy to is that when you go to meetings of sort of organized societies and you talk about this, for reasons that are just completely not clear to me, this is a very hot button topic. People feel very strongly about whether simple decompression, subcutaneous transposition, submuscular transposition is the right answer, period. I don't care what the data says, they have an opinion that I don't know why, it's very emotional for people. So there's an ongoing movement actually within organized neurosurgery, but also, you know, plastic surgeons and orthopedic surgeons treat this fairly frequently too, and have their own organizations that are kind of centered around peripheral nerve or, you know, entrapment neuropathies. And each of the organized groups is in the process of trying to create guidelines to sort of use the evidence to say, this is what the data says we should do with X problem. And anytime we have tried to put together guidelines for treatment of cubital tunnel syndrome, it has been a catastrophic failure because people feel so emotionally about this. And I don't know why. It makes no sense to me when we think about this. So that's the background for all of this that really makes this a challenge. I think your summary is good in the sense that, at least based on the data that we have, I would say that for sort of all comers, simple decompression should probably be the primary operation that you offer to somebody. The outcomes are the same compared to a transposition, either of the transposition operations, and the complications seem to be lower. The thing that is really important, that again was a very astute point, I can't remember which one of you had this on your slide, but it was a very astute point, that there are really diverse outcomes that are reported in these studies. And this is a really big problem in neurosurgery in general, but especially in peripheral nerve surgery, and even more specifically for cubital tunnel syndrome treatment. You know, as I mentioned in the last article, there's 5 or 6 different scales for just grading the severity of cubital tunnel syndrome, none of which are agreed upon as kind of the gold standard. Some studies report a patient-reported outcome, some don't, some check sensation, some don't, some have a pain outcome, some don't. What we really need is a core set of outcomes that every study across the board is going to use, so that when you publish these things and eventually you accumulate several studies, it makes it very easy to combine the data and do a really good meta-analysis. To do a meta-analysis like they did, you're forced to kind of dichotomize the data that's there into yes improvement or no improvement, and that's the best you can do. And there are some real limitations to that. You know, understanding whether one of these two operative choices makes a bigger difference in motor versus pain versus sensation. You know, it may be that they're conflicting actually. And understanding what specific symptoms are most likely to improve with one specific operation is really important, and we don't have that data. I'll pose a question and see if you picked up on this. So they say that there is a difference in the deep and superficial infection rate. What's that based on? I guess, let me ask it a different way so you don't have to read my mind. Is that they used 3 randomized controlled trials, I think, in this meta-analysis or systematic review. Did all 3 of them show the same thing?
I didn't go back to look, to be honest.
Yeah, they didn't. It's really largely based on one of the 3. There is one of the trials that showed a pretty significant difference in the deep infections in particular. And the number of deep infections that occurred in that trial is out of proportion to what most of us see when we do transpositions. And so when people make arguments to say, we don't really have data that we need to be able to make guidelines, they say that study just can't be believed because it's nobody else's experience. Nobody experiences that high of an infection rate. We don't know why there was such a high infection rate, but it's not believable. It was a randomized controlled trial and it was well done. So in some ways you have to kind of believe it, but I will say it has not been my experience that when I do transpositions, I have not seen a higher infection rate. It just hasn't happened. In all of the ulnar nerve surgeries I've ever done, and I do a decent number of both simple decompressions and transpositions, I have never had a deep infection, not one. And so the rate that they report in the single study that kind of hinges these systematic reviews, it's questionable, you know, and if you throw that one out, now all you have left is to say that the outcomes are the same across the board. And if you're going to say that the outcomes are the same, well, then why not just let it be dealer's choice? If I'm more comfortable with simple decompression and you're more comfortable with transposition, because that's how you trained, let the surgeon do what they're comfortable with and don't make a guideline that kind of boxes them in. That's what people's argument is. I don't know what the right answer is. The guidelines that I think will come out will be based on the literature and will probably say that simple decompression is the right thing to do. But what we really need is, again, a core set of outcomes. And that's what we're working on at the organized neurosurgery level, is to say that every study from here forward should use this set of outcomes so that we're all speaking the same language and it's apples to apples comparisons. I hope that'll happen in the relatively near future, but we'll see. On the diagram, the anatomic diagram, there are a couple important things. So there, on one of them that you showed, there is a sensory nerve that crosses roughly close to the field. The medial antebrachiocutaneous nerve passes across there. It's just distal to the elbow, and it's a little bit variable where that occurs. Go back a little further. Yeah, so there you can see the branches coming across there on the distal to the elbow. That branch that comes across there occurs in a pretty variable location, but usually when you do a simple decompression, you don't see that nerve usually. When you do a transposition, you definitely do. So there is more risk probably to injuring that nerve when you do a transposition operation. And that is something that is not tracked in any of these studies. And it would be interesting to know if there is more pain related to injury of that nerve. The other thing that generally is not tracked really in most of these studies is incisional pain or elbow pain. The incision for a transposition is larger. When I do a simple decompression, I make about an 8-centimeter incision. When I do a transposition, I make about a 14 or 15-centimeter incision, so it's much larger. There's a fair amount of stripping of the subcutaneous tissues, and if you do a submuscular transposition, you're cutting through a big wad of muscle. All of that stuff, I would think, hurts, and we don't do a very good job actually of tracking the pain outcomes, not for the nerve, but for the surgical bed in any of these studies. So, you know, I think there are a few shortcomings to the studies that are out there that clinically matter. And I think it's still up in the air. Even though this is a pretty reasonably well done systematic review, there are a lot of unanswered questions. One of the really common questions that comes up clinically, we'll see what your thoughts are on this, is that about 10 to 15% of the population has an ulnar nerve that moves too much. It subluxates. So when you bend the elbow, it pops over the medial epicondyle. It's too lax. And some people use that as an indication for transposition. So if you were going to use this systematic review and ask the question, if I have a patient that has a subluxating ulnar nerve, should I do one versus the other? Is there an answer to that question?
I don't remember seeing it in this paper, but I remember reading somewhere else that that was an indication to do the medial epicondylectomy. But I think in this case, if all the outcomes are the same, essentially, like you would still do the simple decompression.
Yeah, so it's interesting. So people use these studies in actually two different ways that are completely contradictory to each other. So it's not studied actually. And so some people say that because it's not studied, you presume that some of the people having simple decompression had a lax nerve and some having the transposition had a lax nerve, and it all comes out in the wash because it's randomized. And if the outcomes are the same, then you should still do a simple decompression. That's what some people argue. Some people argue that it's not been studied and it physiologically doesn't make a lot of sense that you would let the nerve just continue to kind of pop over the epicondyle, because maybe that's what is creating some of the symptoms. And so they use that to say, well, in that circumstance, I'm going to transpose it. That's actually how I think about it. I think with no data, I think a lot of people do get symptoms from the nerve popping over the epicondyle. And so for that reason, I transpose it so that it's not moving anymore. Whereas I do a simple decompression for almost everybody else based on this data. But there's not good data. It's another one of the unanswered questions. There are certainly people that I respect a lot that don't agree with me, that think you can get away with just a simple decompression for people even with a subluxing nerve. And it's really not clear. So, you know, if you wanted to think about things that are still unanswered, if you ever wanted to design a study in the future, I would say that's one of the really unanswered questions. Number two would be seeing if the medial antebrachiocutaneous nerve injury rate is different and whether that matters to people. And then number three, my personal bias is towards patient-reported outcomes, because I think at the end of the day, that's what matters a lot to me. I want the patient to come into clinic and say, "Doc, I'm better," right? I don't really care if when I examine them, they're better. I want them to know they're better or to tell me they're better. And we don't have really any good studies that include patient-reported outcomes. So I would like to see that as sort of one of the the future outcomes that we track in good studies. Those are kind of my thoughts on these things.
I just have a really super quick question, Dr.
Yeah.
Wilson. Is that the only time that you do the transposition in your practice over?
Yeah, there's really sort of two or maybe three indications, I guess, in my practice. So if it moves, if it subluxates, I transpose it. And my standard transposition operation is subcutaneous. Again, because I think the outcomes, at least in the studies for submuscular and subcutaneous, are the same. The submuscular operation is a much bigger operation. It really hurts people. It has a risk of weakening those muscles that you're detaching. It's much more straightforward to do subcutaneous. And if the outcomes are the same, I just think simply, why not do the simple thing? So I do subcutaneous. So I do that for a subluxating nerve. I do that if there is any bony abnormalities around the elbow, like if there's been bone trauma and there's some sort of osteophyte or something like that that may be compressive that is going to be hard to address with a simple decompression, then I just move the nerve away from it because I think that better treats that pathology. And then the third that's a little bit more debatable, I think, and this may also change depending on what happens with the electrical stimulation idea that we talked about in the last paper. But my third indication is really severe ulnar neuropathy. One of the ideas goes that if you do a simple decompression and the patient doesn't get better, then you go back and transpose the nerve. That's what most people's practice is. You're playing the odds when you do a simple decompression that you're basically decompressing the points of compression that are the most common, right around the elbow. But you're not addressing the tension phenomenon that happens with motion, and you're not getting real distal or real proximal. And very rarely there are compression points there that you just don't get with a simple decompression. When you do a transposition, you address this tensioning phenomenon and you really widely decompress the nerve proximal to distal. So in people that have really severe ulnar neuropathy, my opinion is you probably only get one chance to get them headed towards recovery. If you decompress them, do a simple decompression, they don't get better, and you're 6 months or a year down the road, you've probably missed the window to help them when it's really bad. So I give them the sort of full boat operation usually. I transpose those because I don't think I have the luxury of time to see if they're going to fail a simple decompression. The other thing that's not in this meta-analysis, that's the other kind of new idea for treating severe cubital tunnel syndrome that probably will be in future meta-analyses or systematic reviews, is there is a nerve transfer that's now being used also. It involves taking the distal part of the anterior interosseous nerve and connecting it to the side of the ulnar nerve in the distal forearm, basically as a supercharging operation. That's what they call it, a supercharge end-to-side nerve transfer, or SETS transfer, SETS. And there recently was actually a randomized trial looking at simple treatment, so decompression alone versus decompression plus the nerve transfer in severe cubital tunnel syndrome. And the nerve transfer adds something. And that has definitely been my experience in practice. So when I have somebody that has really severe cubital tunnel syndrome, I transpose them and I do the nerve transfer. Now, what it may turn out to be in the future is you may get the trifecta. You may do transposition plus nerve transfer plus stimulation. And I think that's the way that it'll start to go. We'll see. I think the jury's out on that. But.
Thank you.
Okay, great. Our next presenters are Jose and Collins. If one of you, see if you guys can share your screens. If not, I have your presentation. And thank you everybody for your patience and for hanging in with us. I know we're a little bit over time here.
Well, first of all, thank you so much, Dr. Wilson, and thank you, Nick, and thank you everybody else who presented. And Joe's, I will go ahead and share my screen. Can you see my screen?
Yeah, but you're not full screen yet.
Just a moment.
There you go.
Yes.
Perfect.
Fantastic. Joe, so I will go ahead and present myself first. Well, my name is Collins Hart. I'm a former concert pianist and a track and field athlete in 400 hurdles. I'm from Finland. And I'm also a member of a Congress of Neurological Surgeons. I've been helping neurosurgeon during neurosurgical operations, and I'm working on several publications at the moment. And I'm very excited to present my 5th presentation on clinical outcomes after neurolysis for the treatment of peroneal nerve palsy. And my colleague, Jose, would you like to present yourself?
Thank you, Dr. Collins. Good evening, everyone. My name is Jose Chacon, currently a medical student at the American University of Integrated Science in Barbados. And we're here to present this topic to everyone to hear there.
Fantastic. And I just want to quickly say that it's actually 4 o'clock in the morning, and I'm I'm currently doing neurology, my 2nd neurology rotation in Finland, and I'm at the hospital right now. And but yes, we'll go ahead and start the presentation in just a moment. Yes. So basically, I just want to start with the abstract and quickly touch base the more important topics on, for example, peritoneal nerve palsy, also known as PNP, is the most common nerve paralysis in the lower extremity. And the etiologies of PNP includes compression of trauma, diabetes, aerogenic injury, and idiopathic causes, with the most common cause of PNP being compression of the common peroneal nerve at the fibular neck by the surrounding facial tissue, most often the posterior crural intermuscular septum, and of course, blunt trauma and fibular fractures can result in axonal nerve injury, whereas diabetes is theorized to cause PNP due to swelling of the nerve from the sorbitol accumulation. And a clinical diagnosis of PNP is often confirmed with imaging or electrodiagnostic studies such as nerve conduction, velocity studies, and electromyography. And current management is actually non-surgical management of PNP includes physical therapy and orthotic devices. And the surgical management includes neurolysis, primary repair, nerve grafting, nerve transfer, and finally tendon transfer. And aim to summarize the functional and the sensory outcomes of the neurolysis for the treatment of PNP at the level of the CPN, focusing on the successful return on of dorsiflexion at the proximal matrix. And Jose?
Thank you, Dr. Collins. Basically, what we have here in this slide is just showing you the basic anatomy of the common peroneal nerve. As you know, that a common peroneal nerve is the continuation of the femoral nerve off from the lumbar brake sacral plexus on the interior aspect of the leg. And then once it reaches past through the passing through the popliteal fossa, it splits its branches between both the superficial and peroneal nerve. And of course, the common peroneal nerve is the branches off into the interior lateral aspect of the leg and the ankle and the foot there. It basically shows you the common branches, so forth there. And as you know, the common nerve is most common nerve for the dorsiflexion of the foot there. And any issues will result in the common presentation you see is known as the foot drop there. And so in terms of the methods that was done to set up the study, what they did was they did a comprehensive search using multiple databases, including PubMed, NBUS, Scopus, and Cronkian Library to conduct the search and evaluate outcomes of neurolysis of PNP or foot drop. Then they format the studies that were defined using the Cronkian collaboration POSIS, which in a little bit we'll show you the dynamics of it, how they set it up there. And then mostly the randomized control trials, cohort studies, and case studies were included in the study, and they found at least 10 of them were included there. As mentioned, the primary outcome was post-operative ankle dorsal report on the MRC scale, which is developed to assist patients with peripheral nerve lesions, basically to assess outcomes and improve and see any improvement of function post-operatively. You're muted, Collins.
Yes, and now we're going to touch base on the results. A total of 914 articles were identified from the systematic literature search. Basically, 10 articles were used for the systematic review, of 8 were used for the meta-analysis. And we do know that the most common mechanism of injury was compressed, for which 200 patients had weight loss as the cause of compression, and the remaining of 16 patients had compression due to postural injury and scarring, hematoma, and immobility. And of course, in terms of functional recovery, there was no statistically significant difference in median dorsiflexion strength after a compression injury, as well for median increase in dorsiflexion strength when stratified based on sex, age, and mechanism of injury. Among the studies that reported a sensory recovery by qualitative amount of recovery, there were a total of 264 patients, of which 186 patients reported completely sensory recovery, 60 patients reported partial sensory recovery, and 15 patients reported no sensory recovery. And Jose, please.
Thank you there. And as mentioned earlier, in this figure 1 here, you show the schematics of how they set up the all the databases to accumulate the desired articles for the study, and from the identification screen through the eligibility, and as well as for their inclusion exclusion criteria, they come up with for up to, in terms of the qualitative analysis, they had 10 articles for it, and for the quantitative, which is the meta-analysis portion, they need articles for this. And as you can see in table 1, it shows you the layout of all the articles that was used for this for the sake of the qualitative analysis there.
Fantastic. Just a moment. Yes, and as you can see here, we have a demographic of studies included in the meta-analysis, and we have here patient, nerves, and sex of the male, and age and time to surgery and follow-up of times. And we can see that the mainly focus here is, for example, in a patient, we have 200 sample, but the mean is, I would say that's, yes, the mainly focus here is basically on a demographic studies of meta-analysis, and quickly we have at the time table 3, we have a mechanism of injury of a CPN, and basically we have 200 patients with a compression, and of these we had a traction of 26, and we had a known idiopathic in 32. And Jose?
Thank you there. And as you can see on this figure 2 here, shows you the ankle dorsiflexion strength for the outcomes, particularly comparison of both pre and post-operative in the meta-analysis portion there. And as you can see from this graph, that as increase of duration occurs, specifically post-operative, that it shows improvement of the strength and improvement of the function of the post-operative stage compared to pre-operative stage there. We look at the next, and on figure 3 next, you find out that this was they were comparing the risk assessment, particularly using odd ratios as a way to
thank you, Jose. And of course, we in conclusion, as we all understand, the meta-analysis of non-randomized observational studies concludes that neurolysis of the CPN at the fibular neck is an effective surgical technique that improves ankle dorsiflexion strength and sensation in patients with PMP. And of course, findings suggested that patient's sex, age, mechanism of injury are not prognostic factors of outcome in neurolysis. And of course, further studies with higher levels of evidence are needed to assess functional and sensory outcome of neurolysis of the CPN to fully appreciate the effects of neurolysis of the treatment of PMP. And here are all our references. We really would like to thank you everyone for attending and allow us to present this presentation. And Dr. Wilson, do you have any thoughts or comments on our presentation? And first of all, I'm sorry, I'm actually doing completing the last 2 weeks of the emergency neurology rotation. So I guess some new patients just came in.
Well, what do people think I'm going to say based on this? I have a theme, and there's sort of a theme to all three of these articles in some ways, that I think. So another meta-analysis, right? Systematic review. What's the big problem here? Well, the big problem is that there's a lack of cohesive outcomes data, right? So as all of you go out and become leaders in this field, one of the things that is my sort of real baby that I want to make a difference with, that I hope maybe you'll come aboard with me and try to sort of take a stand on, is we need consensus outcomes, right?
Of course.
When you do a study, your study is not only I think you think about doing studies that are very individual, right? I'm going to publish my results, but we need to be better about thinking about how are we going to take the results that I publish in a study and make them useful to be able to combine with anybody else that's going to publish on this topic, right? Power comes in the combination of data. At least that's my opinion.
Of course.
And there's no consensus outcomes for this either. And so there's a reason why really the only thing they analyzed is dorsiflexion strength. There's no patient-reported outcomes that are analyzed. There's very little in the way of pain outcomes that are analyzed. And all of these are really important things to patients. We don't really know how much functionally different these patients are. Now, you might predict that if they have a complete foot drop and most of them are getting back to 5 out of 5 strength, that probably does make a big difference to them. And that's a pretty reasonable metric. But you'd sure like to be able to say that when you assess patients from a functional standpoint, they say, absolutely, this makes a big difference in my life, right? So I think we need a better consensus set of outcomes. One of the things that's really interesting from this data is if you look at the time to surgery, so time of onset until surgery, I think the average or something that they report across the studies is about 9 months. Why do you think it's so long? Or does that strike you as being long, I guess? But why do you think it's so long? I have a couple of thoughts.
Well, of course, there are some preliminary steps that need to be taken, but mainly I would say that it's important to be prepared and to complete certain preliminary steps. But what is your opinion, Dr. Wilson?
Yeah, I think it's two things. I think that there is spine etiologies in general are just more common most of the time.
Yes.
And so I think a lot of these patients get kicked around for a long time thinking that they've got a spine problem. An L5 radiculopathy is the main differential for foot drop. And I think a lot of people get evaluated and managed for having a lumbar spine problem. And it turns out they've got a peroneal nerve problem, and the diagnosis is delayed for that reason. The second thing is, you're on your neurology rotation right now. I think a lot of neurologists see it as their job to keep surgeons' hands off their patients.
Yes, unfortunately.
So they basically try to delay them and keep us from operating on them. And I think at least for this pathology, this is one where that's probably not the right thing. Certainly I'm all for taking an initial conservative approach, but if your patient's not getting better by 3 months or so into their foot drop, you should operate on those patients. We have a really good chance at making them better. You can see from this meta-analysis, the outcomes are really good. This is a very straightforward operation that makes a huge difference to people. And I think one of the things that we need to do is be a little bit more aggressive as a surgical population, thinking about kind of pushing our neurologists to get patients in a little bit earlier to think about interventions that can really change this. The thing that's not really analyzed in this is time to recovery. So, most of the time what we say is that the average time for somebody to go from a complete foot drop back to grade 3. So usually that means being out of a brace is about 7 months after the surgery. So the sooner you get them on the road to recovery, the better it is for their life, right? You just don't want them wasting months and years of their life with a foot drop. So I think that's one of the big things, is thinking about trying to push them earlier in that regard. The other thing that you'll notice, I think, from the data is that, if you look at the number of patients that are included in each of these studies, it's not very many, minus the one that has 200 patients. The rest of them, have, between 14 and 40, 38, something like that.
Yes, Dr.
Not,
Wilson.
not very big studies for such a common problem. It's really surprising that there are not bigger studies. I mean, I've operated on 50 patients with peroneal neuropathy probably in the last year. Why are there not bigger studies on this?
That's
so there's
interesting.
a need for a
Yes.
very common problem. There is very much a need for good studies on this topic.
Yes, Dr. Wilson, thank you so much for your comments, and you're so right. And thank you, Jose, for presentation as well.
One thing I want to add in there as well is that as you know about systematic reviews, oftentimes they're just based on available studies there. We maybe later on they have more, there will be more studies did, but this is what they have from their previous databases there. And sometimes in my previous experience, because one of my first publication was in systematic review, and what we found out was that a lot of times the data was very scattered and oftentimes heterogeneous in nature. And oftentimes that when you're looking for treatment modalities or even compare which treatment modality is better than the other, oftentimes you might as well just say it's based on discretion of the physician themselves a lot of times there. So oftentimes they, despite these issues there, nonetheless, I will still say that it serves as a guide in many ways to lead to maybe we can do another even better studies there, because for this particular study that we've done, majority of them were just were retrospective studies there, except for one that was really a perceptive cohort. But the problem was it has no control or anything to compare on baseline there. But despite that, nonetheless, there, as I mentioned earlier, it still can serve good as a baseline to as a guide to find what more evidence, what more we can do, and maybe do another study there, or even maybe up to date the study that we currently have, and we could work from there.
Yeah, I think that, this is an interesting topic in sort of just surgical trials in general. This is one example where I think you will have a hard time doing any randomized controlled trials, because I don't think there's clinical equipoise, meaning I think that this is a pretty good tried and true operation that does work. And I think randomizing people to conservative therapy, non-surgical, is going to be hard. I don't think you'll have patients that'll agree to that. That being said, the next best thing is a prospective registry, where you have consensus outcomes that everybody's tracking the same thing. You have good baseline data, you have good surgical data, and you have good postoperative data. And you also track the people that elect against surgery, because there will be some of those, and you need to track those as well. That's the next best thing. But the biggest thing that we're missing is this consensus outcomes. You're exactly right that the data is very heterogeneous. And so it's very, very hard to combine, which limits the ability to draw conclusions. That's the big problem, I would say, across the board in peripheral nerve surgery. If there's one take-home point, it's that what we really need is consensus outcomes so that we can have better studies. Our studies are really lacking.
Hey everyone, Ryan Rad here from neurosurgerytraining.org. If you like that video, subscribe and donate to keep our content available for medical students across the world.